Hello and welcome. This is the third in our series on understanding depression, the suicide connection. We're looking today at the broader implications of how our mental health system, which is very fragmented, and I think most professionals and family members will agree, we're looking at it to see what changes can be made. With me, as he has been during the last programs, is a wonderful expert in our community, Dr. James Jordan, my co-host. Dr. Jordan has been 25 years, correct, Dr. Jordan?
That's right.
At the helm of the Ham Psychiatric Clinic in St. Paul, recently retired. He's also the past president of the Minnesota Psychiatric Society. We're going to talk about a lot of things today. Do you want to preview some of the highlights?
I will, Mary. Thank you. In our lifetime, 1 in 5 of us will develop a major depressive illness. This is a very, very serious and important thing to look at from various perspectives. Today, the public health perspective, the community health perspective, the family medicine perspective. We are going to have a conversation with Dr. Ed Ehlinger, Dr. Mac Baird, Dr. Ehlinger, the Commissioner of Health in Minnesota, Dr. Mac Baird, the head of the Department of Family Medicine and Community Health, are going to tie these various perspectives together so that we can look at this very, very serious prevalent problem that all of us in one way or another are going to face. We want to improve our capacity to address it and take care of ourselves, our family members, our co-workers. So we are going to begin that conversation now.
We do need to take a quick break. We'll be right back with our distinguished guests. We're back. As my co-host said to me yesterday, our two guests are very strategically placed in our state and community to make a big difference, and not only in our state, but also our country. With us now, as Dr. Jordan told you, first is Dr. Ed Ehlinger. Dr. Ehlinger is the Commissioner of Health in Minnesota, a post you've held since 2011. Before that, he was the head of the Boynton Health Service at the University of Minnesota. He also hosts his own television show on health, so you have seen him a lot in very different ways. Our second guest is Dr. Mac Baird. Dr. Baird is head of family medicine and community health at the University of Minnesota. He has been there, I'm not sure how many years. 12 years. He's also a family therapist, which I think is pertinent for this, this topic. And you are on a task force right now looking at suicide prevention for Minnesota. So welcome to both of you.
Glad to be with you.
Thank you.
We have lots of questions. I'm going to let you hit them with the first question, Dr. Jordan.
Thank you, Mary. I'd like to start into this conversation with both of you. Let me just start with Dr. Ehlinger. Do we have an epidemic on our hands, Ed, as far as major depression and suicide? The newspapers are talking about this a lot, the prevalence, our vets returning from overseas. What does public health think about using terms like epidemic?
If we use epidemic when we try to say that there's a crisis, that things have really changed, that there's a large number. And in terms of large numbers, yes, we do have a lot of people who are depressed. We have too many people committing suicide. So if the word epidemic gets people to respond to an issue that has been with us for a long time, I don't think this is a new problem. This is a problem that we've had for a long time. I think people are recognizing it more. They're more willing to come forward with their issues, and we're willing to really try to wrestle with how do we address this. So the word epidemic says there's sort of a crisis. Well, we've had a crisis for a long time with depression and suicide in our society, and this is just a good time to really re-energize ourselves to address that.
Come to the surface. It's in our perspective, professionally, families, individuals, in the workplace, etc. Can we learn things from public health illnesses in the past that have in fact been prevalent and in fact have been at a crisis level? Can we learn from having handled those particular illnesses and applying some of those particular measures to taking care of major depression and suicide, and now that we're aware of the fact, as you say, it's so common and part of our everyday life?
What I'm trying to do as Commissioner of Health is to talk about what creates health in our society. And our narrative generally is that if we're going to give health, we have to have a good healthcare system. And so we've medicalized all sorts of things. And we say, well, we focus prevention on early identification and treatment. I'm really saying, let's go farther upstream. What do we have to do to prevent mental illness and other kind of conditions from starting in the first place? That's our experience with infectious diseases, for example. Treating infectious diseases with antibiotics was effective, but not as effective as having clean water and having vaccinations, that we can really prevent some of these things. And I think that we have not focused enough time and enough energy and enough resources on saying, what is the primary prevention for mental illness? What are the things that we can do in terms of our policies and our systems that actually keep people from advancing to a mental illness? What do we can do in our society to keep people healthy, both physically and mentally?
Could you both speak to that right now? What are a couple of the key things that you think are preventative when we look at the big problem of mental health?
Well, I could chime in a little bit, and Dr. Ehlinger might add other components to it. But one of the dilemmas we face in a busy office practice where professionals work is that we are seeing lots of people with distress. And many times, in fact, we're better than we used to be about screening for that depression and other distress. But sometimes we screen positively many people that are worried and concerned but not ill, not severely ill. And if we're too tied up with those that are worried but not severely ill, we might not be able to turn our attention to those who aren't complaining but are more seriously ill or at risk. And so the good news is we're more systematic about screening for distress and depression. The bad news is we don't always have resources to care for a group that might be overtreated a bit and overdiagnosed, and then not have enough resources for those that are more disturbed, more seriously ill, and at risk for suicide.
And we do have a shortage of healthcare professionals treating mental illness.
Well, we certainly do.
Don't we?
Now, we are responsible at the University of Minnesota for training residents in family medicine and other health professions in our clinics. We're the academic home for 8 out of 11 family medicine residencies. So that's about 75% of those training in this field. And we're training them to be screening and working collaboratively with other health professionals and other mental health professionals, and not to try to do it alone, but do it as a team. So there are many factors that go into doing a better job. But again, if we're screening and we're not careful, we overdiagnose and overcall distress as major depressive disorder unless we're very careful. To be more diagnostically accurate, we would want psychiatrists and other skilled mental health professionals in our presence in the clinics. There are not enough of those, not only to do it, but to know how to do it in this collaborative shared care model.
Can I ask you to speak a little bit more about that collaborative practice model? Minnesota is not far away from beginning to put those pieces together. I feel and believe in our state we have the pieces to fill in this puzzle here and have this collaborative practice model happening and have access to it. How are you thinking about the timeline on integrating these practices?
Well, I thought the timeline was present right in front of us about 25 years ago when we started some of this, or longer ago. And I do think it's on the horizon. We have pieces, we have health professionals more likely trained together now. We have more mental health professionals in our various clinics in training. And then when we get to the practice environment, they graduate from various training programs to go into practice. There's still a dilemma of how to cover all the economic demands on that practice that they're landing in with having a professional on tap that I could call right away when I need it for someone that is distressed now or depressed now or expressing suicidal thoughts. But if that gap in time is too long between my request and the response, the patient can drift away or feel like we didn't respond. And so we can lose them into further despair. So I think it's on the horizon. And our trainees are asking more about it and seeking it, but it takes a combination of training, practice structure, and payment reform, for example, to help that happen.
That's one of the things that we're certainly trying to do at the state level as we look at how do we have our healthcare system better respond to the needs of a community and the needs of an individual. So we've started with healthcare homes, where we really say everybody has a primary care healthcare home. And that primary healthcare home is not just the doc or the nurse practitioner, it's actually a team of folks, including the physician and the nurse and the nutritionist, but also the county caseworker and the public health nurse that really need to be part of that team, so that you treat the individual within the context not only of his or her clinic, but also in the context of his or her community. And so that you can start to deal with some of the supports. So if somebody has problems with housing, they know how to get that housing taken care of, because that's a huge stressor that really impacts the mental health of individuals. If education is a problem, they have a way to deal with education and all of the services that are there. So we're really trying to integrate medical care, public health, and social service in a new way. We're doing this in Minnesota with our accountable care communities. We're really looking at embedding the healthcare within the context of the community and looking at the health of a population in addition to the health of the individual.
There's some nice models out there. I know with TB, they actually go out and bring the patient in if they're not compliant. I mean, I don't know if we can do that in mental health, but there's some models for
the home visiting that public health
out.
nurses have done for a long time has been really successful, particularly with early childhood, to teach moms and dads parenting skills, assessing what's going on in the home. It's been very successful, has been shown to be improving in healthcare outcomes, but also reducing costs and improving child development and educational attainment. This is a huge way to go, and I think that's what we're trying to build with our healthcare homes and our community care teams that are part of that healthcare home.
Can we say, as of today, that good practice, based on what we know from a family medicine, community health, public health perspective, does require integration? So the days of siloing, psychiatry here, psychology here, social work here, family medicine over here, good practice, good training requires being trained up and for that integrated practice model.
Well, actually, that has just happened. Just about a month ago, all the primary care organizations in the country, both those that are academic and in practice, signed a document that declared that a healthcare home or a medical home at the national level must include integrated mental health. This took several years to develop, and I was on several committees that helped contribute that. And it is declared, now it's not actioned yet, it's not actionable, but the national and local criteria already do in Minnesota include that request. And one of the things we're doing is training our staff so that they assess for those social factors that often are have a huge impact on not only overall health, but mental health.
This may help me get into the next question. And this is a tough one. There's a lot of medication being prescribed out there. My colleagues are prescribing a fair amount of it, but yours, the family medicine doctors, are prescribing most of it.
Correct.
Most psychoactive medication. Will these changes, taking time, having these integrated practices, dealing with the stress factors, getting in front of the illness, taking care of the things that families and individuals need, exercise, for example, taking care of your general health, things like that. Are we going to see some change, or is medication a problem in and of itself? Do we have problems because of the amount of medication that's being prescribed and how it's being monitored or partially monitored or not monitored? Where does that fit into this discussion? Because most people are thinking about depression, drugs.
I've been on about a 30-year discussion in that zone, and I think we are part of the problem when we're over-prescribing psychoactive medications. So again, if we screen for depression, for example, and because of the screening instruments that are available to us, we're likely to have very many positive screens for people that are in the mid-range of depression and discouragement and anxiety who don't respond well to medications actually, but we prescribe because we want to do something. If we don't have ready access to a clinician in mental health with those clinical interactive skills, when we get anxious and we want to help a lot, my signature comes out.
Do something, right?
Do something. If you don't know what to do, do something. And we write too many prescriptions. Secondly, the thing that you alluded to earlier on the suicide risk is too many pain medications. When we're prescribing powerful narcotics now for chronic pain in a way that doesn't lead to the rather rapid sort of response and then discontinuing that medication, those chronic narcotics are lethal. So when a combined lethal access to means not just guns but now narcotic medications, which then has become known that it's cheaper to buy heroin than it is the medications we're prescribing, we've contributed to a public health problem, not helped it. And it's not intended, of course, but without those clinicians in mental health to support us to say, you know, we should stop that medicine or taper it now, or we should respond to psychotherapy, community support, a community health visit instead of a medication, job training, adolescent development skills instead of medication for what is possibly overcalled ADHD. So we're prescribing medications in unwise quantities for unwise periods of time because we don't know what else to do. We don't have access to other tools. We need those tools.
Let me just ask you this one, flipping it over on the other side for a moment. When we stratify a risk for someone that has a serious and persistent mental illness, we know this. We know that they must take medication. They must take it in the long term. That must be followed carefully. We have to make sure that they do not take other substances as a substitute for taking the correct medication for their illness. How can we do a better job of this? Getting back to the public health issues where this is the group, let's say a risk factor, when we stratify the risk and we see that they could very well have a outcome of suicide if they do not take care of themselves with this chronic illness. Is there something that we can do, let's say from a public health point of view, in taking care of these individuals who have that degree and severity of illness, mental illness?
Well, certainly from a public health perspective, we want the medical care system to be as high a quality as possible and as effective as possible, and we really do look to the medical profession to do that. We will support with any kind of community supports with community outreach workers, community health workers, public health nurses to help support those individuals. But you know, we really do look to our medical care system to do a good job. But I agree with Mac. We give too much medication right now, and we need to also look at different ways of doing that. And I'm actually looking farther upstream to say, how do we keep from overwhelming our medical care system with people who need drugs by doing the preventive things? We haven't talked about adverse childhood experiences, which is new data coming out that says what happens to those infants and children in the first year or two of life has an impact on whether or not they develop mental health issues in the future. Things about like family system distress, child abuse, sexual abuse, low income, chemical
Racial
use,
disparities,
and disparities.
About.
And so that actually so we identify those and we say, all right, let's do trauma-informed care based on what we're finding. But I'm saying, how do we prevent those adverse childhood experiences in the first place? How do we increase the minimum wage, which is a huge public health issue that'll reduce stress on folks so they don't have to work multiple jobs and not be at home? How do we get paid parental leave so that when a family has a baby, they get to stay home for 6 to 10 weeks or longer taking care of that baby? Will increase the bonding between the baby and the mother and father and really reduce stress? You know, how do we advance people in their educational attainments? All of those things will really prevent mental health problems in the future.
I would just like to add that I'm bursting with this response. So it takes not only a healthcare home that's well supported, and Dr. Ehlinger and others are helping do that with various payment methods that are helping that. It takes a healthy neighborhood. So what he's talking about is making the whole community interacting in a way that's more supportive. So we need that response. We talked earlier about the risk of suicide. So when we see people that are distressed or they're under responding to treatment, we need assistance that's not just on the medical side, but the whole community can respond. And suicide prevention is everyone's job. It's not just the professionals that are in teaching and healthcare. Neighborhoods, others can respond and say, if Mac is discouraged someday for weeks at a time, can a neighbor come over and say, Mac, how are you?
Would you just make a 1 or 2 statement comment on the fact, though, that as you told me earlier, not all suicides are preventable? Because I think for families, That is an important thing to hear.
Well, it's an information that is now becoming more publicly discussed. Not all suicides are preventable because people just suddenly are impulsive and do things out of the blue that no one would have anticipated, no matter how we're screening or attending to them. And secondly, it does affect so many people. So there are suicide risks and then attempts. And if we can help at those moments, it's the repeated attempt that then escalates into suicide. And if they aren't having ready access to lethal means, our medications or other things, vehicles and guns. But we have to respond in a more complete way, and it is not always preventable.
We need to wrap up. Thank you both so much. You've raised a lot of questions. We're hoping that by looking at this, we raise awareness, we get more people wanting to take action at a broad level. In the university system, as you said, you're doing so much of the training. We'll be back in just a few moments with a wrap-up and kind of a summary of not only this show, but the series. So stay with us. We'll be right back. We want to wrap up our series as well as this interview. And Dr. Jordan, we covered a lot with Dr. Ehlinger and Baird. Do you have some observations or comments or disagreements with what you heard?
I sure do, Mary. First of all, I want to thank my colleagues for coming and talking to us from their perspectives. Public health, family medicine, and community health. If you listen, which I know our audience did, to Dr. Ehlinger and what he said in a very, very clear way, was that prevention is our long-term best strategy for dealing with major depression.
And with suicide?
And with suicide.
Because suicide is one of the
Tragic
high-risk
outcomes,
things, isn't it? Mm-hmm.
And it's there. We cannot predict when this will happen. He did speak about that, as did Dr. Baird, in terms of our stratification of risk. In other words, how we determine when we are thinking about this possibility and the warning signs, which I can mention a few. If you see someone, behavior, mood, drinking too much, sleeping excessively, unable to sleep, agitated, not performing, a personality change, they're clearly depressed, have been taking medication, and they're not improving. These are the kinds of things that should raise our concern, the family's concern, the doctor's concern, about looking more carefully, more closely at this as a possibility for some complication that could end up in their taking their life. Suicidal thoughts are part and parcel of major depression.
I think a lot of family members have been concerned that if someone in their family or a friend is talking about suicide, and if they ask them more about it, they might make it more possible. But this isn't true, is it?
It's exactly the opposite.
Mm-hmm. That's important for people to hear.
It's exactly the opposite of that. To be alert to the fact that, like a cough, when you have pneumonia, is part and parcel of that illness. So suicidal feelings and thoughts are part and parcel of having a major depressive illness. You can talk to people, and you should talk to them about the fact that it is there. It is something that you can understand, you can help them and support them, help them receive and get help, the assistance that they need, medication if that's appropriate and needed, which often it is. That needs to be integrated into our total understanding of this illness.
A lot of people, I think, are not sure whom to go to when they are feeling really seriously down. Not knowing if their family doctor can handle it, not thinking they can afford, perhaps, to see a psychiatrist. What's your best advice, Dr. Jordan, in terms of where do people go first?
The first port of call when you want to get a consultation and an opinion about this particular possibility, depressive illness, is to go to your family physician. Family physicians, as Dr. Baird pointed out, have now agreed that the family home is really the home that they have built for you and for me and for us, to go there as a home, to put ourselves at that portal of entry, and also say that we're there for that particular assessment. Just as we're there to have our blood pressure taken, we need to develop a vocabulary so we include this in a discussion of our day-to-day life.
So don't make the physician guess in
Absolutely
terms of what's
not.
going on.
No. I think you can practice, and that gets back to your earlier question about talking about it at home. If you see someone that's depressed or they're being treated for depression, it's perfectly reasonable to talk to them about the fact that they probably, likely, have suicidal feelings or thoughts. That doesn't necessarily mean they're going to act on it. So we want to keep that door open because it's a nice barometer of how someone is progressing. As soon as those thoughts start to abate, you can see that you're coming out of it, you're improving. That can take months on the average to come out of a major depressive illness. So time, support, and then following with your family physician the care plan that you have towards getting to a point where you're now feeling back to your usual functional self.
We want to thank you, viewers, for watching this series, for helping bring awareness, for taking this topic very, very seriously. We also want to thank KSDP Television, and we would like to thank our underwriters who've made the series possible. We will leave you with the National Suicide Prevention Hotline. Thank you again for joining us. If you are feeling desperate, hopeless, and/or suicidal, please call the National Suicide Prevention Lifeline. That number is 1-800-273-TALK or 800-273-8255.